Hey guys, this is Charity Stanley, and today we're talking about when the autoimmune system, your own immune system starts to attack your nerves. And so that creates really major conditions, and has a lot of consequences for the patient. So the big thing that we're going to be talking about today is going to be looking at different immune diseases, such as Myasthenia gravis, multiple sclerosis, and Guillain-Barre syndrome. So with those are the big ones that we're going to be hitting today. And we'll have a few other autoimmune diseases added later on. So your patient with multiple sclerosis, they tend to be really young people, also tend to be female. The onset is between the ages of 20 to 40. It has a genetic susceptibility. And what they have found is that the myelin, instead of smoothly coating the nerves, starts to create chunks. And the myelin plaques is what starts to affect the way the nerve is transmitting. With multiple sclerosis, you tend to see problems within the spinal cord, the brainstem, the cerebellum. Cerebellum is our coordination center for motor that's in the back of the brain. And then the cerebrum, which is the hat that is all crinkled, and that's where we store memories, different aspects of the brain, movement cortex, sensory cortex. So all of these facets will be changed of sensory perception, motor control, weaknesses, being able to walk, dizziness, and exhaustion. And that's one of the key tenets of multiple sclerosis. So the first stage is just inflammation. The later stage, the glial cells, and glial cells have a really cool job within the brain. The glial cells actually are the helper cells for the neurons. So they will go through and clean up the cellular waste and cellular debris from all the junk that gets left over from living life and the brain waste products. So gliosis is when the glial cells stop working. And so what happens if the cleanup crew stops working? You're going to get a lot of other waste products in the brain that's going to cause further problems. So with that, we're also going to see demyelination. So at first we talked about it creates plaques and creates chunks of the myelin, but later on it actually creates problems with the myelin coming off the neuron. This slows neural conduction, and so it's much harder to get the signals where they need to be. There's several different directions that multiple sclerosis can take. First is going to be a relapsing remitting. This tends to be the most common. This type of multiple sclerosis, you have severe problems and then it goes away and you're almost normal for a while, then you have problems again. Those of you that are fans of the TV show The West Wing, this is what President Bartlett had, was relapsing remitting multiple sclerosis. So for a long time, he was able to keep it hidden from even people on his core staff that he was actually ill. Another course it can take is called primary progressive. Primary progressive is when it starts and continues. And it's really unknown what the initial factor is that starts the decline. Secondary progressive is going to be related to some other neurological autoimmune inflammation condition that kind of acts as the trigger. Now, progressive relapsing. This relapsing remitting can go into progressive relapsing as you are having more relapses. So what the difference is between progressive remitting and relapsing remitting is the return of the patient's ability to go to do their everyday life. So with relapsing remitting, you're down for a few days, then you're back and you're just as good as you were before. With progressive relapsing, your condition, each time you relapse, you lose a bit of ground. So you're more severe than you were the previous time. So manifestations of MS, it's going to depend on the area affected. So again, those plaques are not going to be something that happens all over the brain initially. So where the plaques, where the deterioration is going to be what determines what your symptoms are. So it starts off with sensory loss, visual deficits. You start to see double, may have trouble focusing. You may not be able to feel your leg or feel one of your arms, or you lose the ability to feel the need to pee. And so you may have weakness. You may be feeling pins and needles, paresthesias, ataxia, have trouble walking. Vertigo it is an extreme form of dizziness that is really difficult to be able to function while you're experiencing vertigo, and severe fatigue, as we talked about. With multiple sclerosis patients, we really need to be able to connect with other professionals, and this is really a multidisciplinary disease. We need to have neurology on board, need to have occupational therapy, physical therapy, different allied health occupations working together to help the patient. So the diagnosis is going to be based upon the way it manifests. What are the symptoms that the patient has? Based off of an MRI, because you can see the plaques start to develop within the brain. Looking at cerebrospinal fluid, you're going to see an increased number of T cells. This is going to be both T4, the helper T cells, and also T9, the killer T cells. Okay. Also be looking at a CT scan of the brain, because that's also going to show us if there's changes within the ventricles and large global changes within the tissue of the brain. Several different medications are given for patients with multiple sclerosis. One of the medications is going to be steroids. We're going to give them steroids to help turn off their immune system, to stop their immune system from attacking the neural tissues. Something else is going to be immunomodulators. These are going to be medications that actually change the way the immune system works and the way the immune system attacks. So with these immunomodulators, the goal is to be able to slow down the progression of the disease, to be able to have longer periods between the exacerbations of the disease. We may also need to be using muscle relaxants. So spasticity and muscular contractions can be a key part of multiple sclerosis. So how do we treat multiple sclerosis? Some of the key ways that we treat it will be surgery. Why would somebody with multiple sclerosis need to have surgery? If they are experiencing severe spasticity or severe deformities within their limbs, contractures, we can use surgery as a way to be able to help them be able to move more freely. Nutrition. Frequently, people they'll start to gain weight the less they move. Now, if you're not able to move due to ataxia, spasticity, fatigue, weakness, ataxia, then you're not going to be able to get up and exercise. So the pounds will start to accumulate, and this in turn makes the multiple sclerosis a more severe problem. Dysphagia, swallowing problems, is also common with multiple sclerosis. So we would need to have speech therapy involved as well to help ensure that our patient is safe. Rehabilitation, we need to have them involved with speech therapy for swallowing. They may have to have respiratory therapy consults to make sure they're oxygenating, make sure that they have physical therapy consults, occupational therapy consults, that we're stretching and doing passive range of motion. And if the patient is able, active range of motion exercises and activities. We want to use gait training. The gait training is a way to be able to keep them walking and keep them moving for a longer period of time. If weakness in the legs is a severe issue, there are certain types of assistive devices and braces that we can get that will help the patient be able to put weight and be able to carry their weight to be able to continue to walk. Nursing care of patients with multiple sclerosis. Big thing is fatigue. If you are so tired all the time, what is going to happen to your ADLs? You are not going to be able to engage in your ADLs as effectively as you could in the past. So with this, they tend to stop taking care of themselves. So they experience a self-care deficit. So with continuity of care, we want to be sure we're straight up with the patients and provide them options for their treatment and let them know what different ways they can be involved in their own care. We also want to give the patient information on different services that are available to them in the community. Okay, our next disease is Myasthenia gravis. Myasthenia gravis is a really, really messy disease. In the emergency context, if you're working in the ER and you find out your patient is coming in with Myasthenia gravis, you need to have an intubation kit pretty close to that room. Because what happens with Myasthenia gravis is their diaphragm can be attacked. And there's a couple of different ways this could happen. But either way that it happens, the end result is the patient needs a tube to be able to maintain oxygenation. So myasthenia gravis is a chronic autoimmune neuromuscular disorder. Again, like MS, it has periods of exacerbation and periods of remission. So pathophysiology, how does this work? So the antibodies will actually decide that the neuromuscular junction receptors are foreign invaders. So they must be killed. So they will attack where the neuron attaches to the muscle and tells it to move. So for your diaphragm, if that neuromuscular junction is attacked, that is telling you to breathe, we have a big problem because you're not going to want to breathe. We also have a downregulation of acetylcholine receptors. Downregulation, all it means is there's a decreased number of acetylcholine receptors. And with that, that further causes problems with the muscular contraction. So we will need to give them medicines that will help to increase the amount of acetylcholine to help compensate for that downregulation of those receptors. What's our patient going to look like with myasthenia gravis? It's going to depend on which neuromuscular junctions have been attacked the most severely. So if the ocular muscles have been attacked, you're going to have diplopia. The patient's going to be seeing double. We may also have a drooping of the eyelid. That's ptosis. Facial, if the facial nerves are being attacked, you're going to see problems with swallowing, dysphagia. Again, need to get speech therapy involved. Dysarthria, you're going to have trouble moving the muscles in your face. Now, these neuromuscular junctions are all throughout the body where any muscle is. So we're going to experience systemic body-wide weakness and fatigue and decreased ability to function. Respiratory-wise, we're going to have decreased diaphragmatic movement. again, because the neuromuscular junctions are being attacked and we have fewer acetylcholine receptors, the gas exchange is going to be crappy. See why we're heading for a tube? Also, we can have shortness of breath. Now, nutritionally, if you can't chew and you can't swallow, your nutrition is going to collapse, which is going to further exacerbate the myasthenia gravis attacks. So other complications of myasthenia gravis, you can have the two pathways that we talked about. You can have a myasthenic crisis, which is going to be a sudden exacerbation of motor weakness. So all of a sudden, I become very fatigued. I can't move my muscles. If I can't move my muscles, I can't move my diaphragm, I can't breathe. Okay, so the next direction that it can take, that our patient is taking, is going to be a cholinergic crisis. And this occurs whenever the patient has received too much anticholinesterase medications. It's going to have the exact same effect because the anticholinesterase is going to destroy the acetylcholine breaking down enzyme. Okay, so that's going to have the net effect of increasing acetylcholine. If we have too much acetylcholine, we will have the same effect of spasticity and, again, not being able to breathe. So how do we examine this? How do we figure out what's going on? The first way is through an anticholinesterase test. The second way is through looking at myography, and this is basically an EKG of the muscles. We're looking at the electricity within the muscles. So we will put electrodes on the different muscle groups and then tell the patient to do different activities that engages that muscle and look at the electricity that is happening within that muscle group. We also can look at anti-acetylcholine receptor antibodies. These are the antibodies that destroy the acetylcholine receptors. So if we can stop those antibodies, we can slow the progression of the disease. Other medications that we would be using is going to be anticholinesterases. And also, as we talked about with MS, glucocorticoids are used. Now, we're going back to endocrine. Remember what happens when I load my patient up with glucocorticoids? Cushing's syndrome. So remember, all of these things are tied together. So be sure to review Cushing's syndrome and what that means for your patient as well. How do we treat myasthenia gravis? First way is through surgery. We can do a thymonectomy, and with this, we're using a transcervical approach. So they think that the thymus is involved. The thymus is in front of the heart. It's an endocrine gland involved in the immune system as well. Or we can do a transsternal approach. That's where we're going to cut the ribs and go in that way. So it allows for more extensive removal of the thymus, but we're cutting your chest open. That's going to be a significant time for recovery for that patient. So we have lots more potential complications. Now, surgery is obviously our last resort, but what we can do is plasmapheresis that we've talked about before. With plasmapheresis, we hook a patient up to something similar to a dialysis machine, and we can use different chemicals or filters to be able to stop certain antibodies from getting back into the blood. So we literally can pull out these anti-acetylcholine receptor antibodies and be able to remove them from the blood before it's cycled back into the body. What do you as a nurse need to be aware of for your patient with myasthenia gravis? Airway, 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 airway. Okay, importance of airway. You're going to have to tube them immediately when you get a patient with myasthenia gravis. They're going to be also having problems swallowing, and their swallowing being impaired leads you to need continuity of care and making sure that you have all the professionals involved with their care that you need. So you want to involve the patient in goal setting and help refer them to resources within the community as well. Okay, Guillain-Barre syndrome, GBS is what it's commonly referred to as. This is an acute inflammatory demyelinating disorder. So with this happens suddenly. Now, immunizations, you're going to see cautions about immunizing somebody with a previous history of Guillain-Barre. And the reason for that is the immune system activation that happens with an immunization can also trigger the development of this autoimmune process on the brain and the spine and of the peripheral nervous system, specifically within Guillain-Barre attacks the peripheral nervous system. It causes an acute onset of motor paralysis. So myasthenia gravis and multiple sclerosis, we have the relapsing remitting. They're okay, they're not. They're okay, they're not. But with GBS, you're fine. You're on the basketball team. You get this injection, and then 24, 48 hours later, you can't get out of bed. So it can be precipitating factors, can be viral immunizations, can also be viral infections or bacterial infections. And sometimes we're not 100% sure what causes it. It can happen with an unknown origin. So the pathophysiology of it is the destruction of the myelin sheaths. And with this destruction of the myelin sheaths, the neuronal conduction is slowed. So this is due to both a humoral, and that is the antibody process that we talked about, and then cell-mediated is going to be where we are actually phagocytizing cells. We're eating those cells, immune system response. But the consequence is poor conduction of the nerves and slowed conduction of the nerves. What does our patient with GBS look like? Within the acute stage, their muscles are going to be super weak. Their sensory perception is going to be off. And you may see involvement of the cranial nerves as well. We're going to see symmetric weakness in the lower extremities. Now, guys, this is the big key. GBS starts low, starts at the legs, and goes up. Okay, so we have paralysis of the legs and weakness in the legs long before we have weakness in the torso and involvement of the cranial nerves. Now, as you work through and treat the symptoms that's happening with the acute stage, you get to the stabilizing stage, the plateau stage. This is where your symptoms level off. You also finally will get to the recovery stage. This is where you get muscular function back and strength back. And diagnosis of GBS. GBS is very difficult to diagnose because we can't just draw blood and say, hey, look, my GBS test is positive. There is no test for GBS. You have to differentiate it from other illnesses, and it tends to be a diagnosis of exclusion. Now, the big key test that you need to order that will point you in the direction of GBS is going to be looking at cerebrospinal fluid proteins, looking at the electromyographic studies. That's the studies we talked about putting electrodes on the muscles, looking at a CAT scan of the head or body, doing a lumbar puncture, looking at that CSF fluid, and also doing a nerve conduction study to examine the speed at which the neurons are conducting the electrical impulse. How do we treat GBS? Big thing is we look at what the most severe problems are. Now, some patients with GBS completely recover, some it takes a much longer time for them to recover, and they may not recover to their same level of functioning previously. So some patients, depending on which nerves are damaged and are not working as well, we may have to put a trach in so they can breathe. We may need to put a pacemaker in to be able to ensure that their heart keeps beating. And then they may have to have plasmapheresis. Again, if we know which antibody is causing the problem, we can pull it out, and that will improve the patient's condition. We need to have contact with other professions and with our patient with GBS. They're having troubles breathing, they're having trouble swallowing. So you've got to make sure that they're getting enough protein. That's what that big fancy term, maintain positive nitrogen balance. If they're not eating enough protein, the muscles that are getting broken down and the neuromuscular junctions cannot repair. You need to make sure they're drinking enough or getting enough IV fluid, making sure that their electrolytes are good. They may have to have an NG tube put in, and in some cases, they may actually have to have total parenteral nutrition. So this is where we put the components of nutrition within their veins. But remember, it has to be a central line that we are using for TPN because it cannot be used peripherally. It tears up the vasculature. We need to make sure that they have physical therapy and occupational therapy. Again, we're wanting to get them back to a better level of functioning, even though we may not be able to get them back to the complete level of functioning they were previously. Finally, when we're caring for a patient with GBS, we need to make sure that we are looking at pain management because this muscle atrophy can be very painful. And if my patient's not moving, what's going to happen to their skin? They're going to be at greater risk for developing pressure ulcers. And then we have a whole other mechanism of disease and comorbidity that patient has to fight. Okay, so if you have any questions, please let me know, okay? Thanks, guys. Bye.